Hello everyone, my name is Linda Hogner. I'm a grad student at George Washington University and in the clinical microbiology program. So today I'm going to be giving a review of a case study, the efficacy and safety of extended release guanfacine hydrochloride in children and adolescents with attention deficit hyperactivity disorder. This is a randomized controlled phase 3 trial. Some key information on ADHD. It is one of the most commonly diagnosed neuropsychological disorders. Onset is usually seen before the age of 12. There are three subtypes, I, H, and C, inattentive, hyperactive, and combination. ADHD-I accounts for 50% of all cases. This is characterized by failure to sustain attention, disorganization, and high distractibility. These symptoms are commonly treated with stimulants such as amphetamines, so Adderall and Ritalin, just to name a few brands. Now, there is a potential for patients to become dependent on these stimulants. Some other methods are behavioral therapy and pharmacotherapy. Now, this study aims to use a non-stimulant alternative. Guanfacine extended release is an alpha-2A adrenergic agonist. It is seen to improve memory and attention. Atomoxetine, also a non-stimulant, is a norepinephrine reuptake inhibitor and has similar side effects as stimulants. Now, the atomoxetine is just used as a comparison for the guanfacine extended release and the placebo in this study. So here we have the actual case study. I just wanted to insert a front page of it just for your reference. So here we have a little overview of the screening process and the termination of patients. So we started with 404 patients. 66 of these failed the screening, and that left the study with 338 to be randomized into their respective treatments. So we have the GXR, which is the guanfacine. We have ATX, which is atomoxetine, and the placebo, which is our control. So we have 115, 112, and 111 respectively. And what I like about this flowchart, if you look at the very bottom, it shows how many patients terminated per each treatment and the reason for their termination as well. So the overview of the study design, we have one for children, one for adolescents, 6 to 12-year-olds, and 13 to 17-year-olds respectively. So during visit 1, we have the screening, and this took around 3 to 35 days. And then at visit 2, we had the randomization, where I previously showed you they were divided up into their respective treatments, which is the guanfacine, placebo, and atomoxetine. In visits 3 through 9, this was the dose optimization. So at the discretion of the physician, he added or subtracted treatment, and this was around 4 to 7 weeks for children and adolescents. Now, we had dose maintenance at visits 10 to 15, and this took around 6 weeks. Then visit 15, we have evaluation. Then we have the tapering of the drugs. This took 2 weeks. This was at visits 16 and 17. And then follow-up visits took 7 days. So respectively, children, this was a 10-week trial, and for adolescents, this was a 13-week trial. So here we have our primary and secondary endpoint results. Our primary one here is the ADHD rating scale 4, RS4. We have our GXR, ATX, and placebo treatments. Our baseline mean standard deviation scores are 43, 43, 43. And at visit 15, this standard deviation score changes. We have 19.2, 25, and 28.1. Now this change from baseline to visit 15, if you go by each row, it's 23.9, 18.6, and 15 respectively. So now we're going to take the two treatments, GXR and ATX, and now we're going to compare them to our control or our placebo group. So the difference comes from this comparison. So if you go down to difference in LS mean with a 95% confidence interval, if you take 23.9 from the GXR and subtract 15, you get your 8.9. And if you do the same for the ATX, 18.8 minus the 15, you get your 3.8. Now, both of these are negative numbers, so this difference in LS mean indicates a positive effect of treatment when compared to the placebo. So now we're going to move on to our secondary endpoint, which is the clinical global impression improvement. Now this is on the y-axis. This is our percentages. So we have our placebo, GXR, and atomoxetine, or ATX. We have guanfacine extended release at 67%, our atomoxetine at 56%, and our placebo at 44%. Now we're going to compare these differences again. So our GXR has a difference of 23.7 when compared to the placebo, and our atomoxetine has a difference of 12.1 when compared to this placebo. Now these are the differences in percentage of patients with improvement for active treatment. So both of these indicate a positive effect of treatment when compared to the placebo. Treatment emergent adverse events. So I included the table from the study. I liked the way it was presented, so I thought I would use it in my presentation. I just cropped the table out a little bit. I just included the 4 most common ones. So if you look at guanfacine extended release, 43% of patients experience somnolence, which is a sedative-like state, 26% experience headache, 25% fatigue, and 16% experienced abdominal pain. Now, all of these are mostly mild to moderate in severity. However, there were 3 patients that experienced severe adverse events. 2 were a part of the GXR treatment, and 1 was the placebo. However, one of them that was in the guanfacine extended release, it was a non-treatment related termination or adverse events. They had appendicitis and therefore had to terminate treatment. So to summarize, this was a randomized, double-blind, placebo-controlled study, produced significant data supporting GXR as an alternative treatment when compared to the placebo group. Dose optimization was used by the physicians throughout the study. So the whole purpose of this study was to give patients an alternative to stimulants when stimulants can't be used due to side effects, pre-existing conditions, perhaps a poor response as well. Now, GXR can be used as a monotherapy, meaning by itself, or adjunctively, meaning in combination to treat ADHD with other drugs. Now, the side effects aren't severe, however, they're still there, with almost 43% experience somnolence, which was this sedative-like state, 26% experiencing headache, and 25% fatigue. So how is this case study relevant? Well, if you remember from the beginning of the presentation, I mentioned that ADHD is commonly treated with stimulants. Now, the thing about these drugs is that they can often make the patient become codependent, and stimulants, like any drug, are not one size fits all. They're not going to be for every single patient that has a case of ADHD. Now, an interesting fact is that those diagnosed with ADHD are inherently at a higher risk of substance abuse disorder. And there are some side effects also associated, as with almost any drug. There's loss of appetite, weight loss, and sleep disturbances associated with stimulants. Now, guanfacine extended release offers an alternative therapy. Now, like I said, it's not the first drug of choice, but however, it is there in cases where the previous stated occur. So this targets the postsynaptic alpha-2A adrenergic receptors. Now this is seen to improve attention, working memory, and learning, and this has been seen in some animal studies. There's a positive effect on impulse decision-making behavior which has been seen in a study with rats, and the safety and tolerability has been well established with guanfacine extended release. So some outside analysis of the study is a criticism is that this drug, guanfacine extended release, targets a specific patient population. So they have to fit the category. Maybe the stimulants didn't work, or they have chronic disorders or oppositional defiance disorder. It's not generally the drug of choice to treat ADHD, but it's a good alternative. So some things that may be exacerbated by stimulants can be weight loss, tics may be exacerbated or induced, or codependence. So in this form, GXR does not stimulate the nucleus accumbens, and this has to do with the regulation of reward-related behavior, and this is where you have your substance abuse disorders come into play. So my personal take on the study. I am for GXR as a non-stimulant alternative option. The treatment is statistically relevant and supported by the data presented in the study. There are some drawbacks, however, which are the side effects, with about 43% experiencing somnolence. So remember, this is this sedative-like state. Also, while researching, I found some conflicts of interest, which are normally stated in the article, and these are, however, I didn't know how deep they went. So research funding came from Shire Development, which is a pharmaceutical company. They're now owned by Takeda, but they're the ones that own Vyvanse, Lyalda, and Adderall extended release. Now, there was a case against them where they're known to violate the False Claims Act, and this had to do with Adderall extended release. Another interesting fact was the contributors in the study owned shares and stock options in Shire. Here's a list of my references. The only thing I want to point out to you is the second to the last one. This is the case against Shire Pharmaceuticals and their violation of the False Claims Act. I left it here for your recreational reading and enjoyment. I hope you enjoyed the presentation. Thank you.